All right, finishing up chapter 31, injuries to knee ligaments. The knee is extremely vulnerable to injury. Oftentimes, you get a lot of different types of injuries because your knee is mostly held into place by ligaments. Ligament injuries can range from mild sprains all the way to complete dislocation of the joint. Your patella itself can dislocate. And then you have obviously several different bones that are associated with your knee, and so those can fracture as well. Your knee is especially susceptible to ligament injuries because of abnormal bending or twisting forces that are applied to the joint. Um, Oftentimes with a ligament injury, you're going to end up seeing swelling. Every once in a while, you get some ecchymosis, point tenderness at the site, and joint effusion, lots of swelling. You should splint all suspected knee ligament injuries because it's really hard to tell the difference between a fracture or a sprain. Dislocation of the knee, their true emergencies can definitely threaten the limb itself. When the knee is dislocated, those ligaments get torn out like crazy. The proximal end of the tibia completely displaces from its juncture with the lower end of the femur. This produces significant deformity, and we want to make sure that we're constantly checking distal circulation before we move on or take any other steps. The direction of the dislocation refers to the position of the tibia with respect to the femur. Posterior is definitely the most common, occurs in almost half of all cases. The anterior is there, and when you do that, then you risk greater injury to the popliteal artery that runs directly below your, or directly behind your knee, excuse me. Medial dislocations, if you take a direct blow to the outer part of the leg, it can displace inside. A lot of times your patients are going to say, my knee just gave out. Fractures around the knee occur at the distal end of the femur, at the proximal end of the tibia, or in the patella itself. It's easy to confuse a non-displaced or minimally displaced fracture with above the knee or around the knee with ligament injury. There's two types of injuries and how to manage them. If there's an adequate distal pulse, no significant deformity, splint the limb with the knee straight. If there's adequate pulse, but there's a significant deformity, splint the joint in the position of the deformity. If you have a pulse that's absent below the level of the injury, you want to contact medical control and find out if there's anything that you can do. Never use a traction splint if you suspect a fractured knee, by the way. Dislocation of the patella most commonly occurs in teenagers or young adults who are in athletics. It often is going to displace to the lateral portion of the leg. It produces significant deformity. The knee is going to be held in a moderately flexed position. You want to splint the knee in the position that you found it. Like I said, most often there's a little bit of flexion to it. So you're going to want to apply padded board splints that are going to help support that position. Injuries to the tibia and fibula, they may occur at any place between the knee and the ankle. Often both are going to be fractured at the same time. Even just a single fracture can result in some pretty severe deformity with some pretty significant angulation or rotation. Open fractures of the tibia are relatively common because there isn't a whole lot between the bone and the external portion of the skin. Fracture should be stabilized with padded, rigid, long leg splints, air splints. You may want to correct a severe deformity by applying gentle longitudinal traction if they tolerate it. These fractures sometimes associated with vascular injury. So if realigning the limb is possible, then that can often return blood flow. If it doesn't, transport immediately, contact medical control. Ankle is a very, very commonly injured joint. There's really no set age group in which this is more common. It can range from simple sprains to severe fractures or dislocations. Um, any ankle injury that produces pain, swelling, localized tenderness, or the inability to bear weight needs to be evaluated by a physician. The most frequent mechanism of ankle injury is twisting, and it ends up tearing or stretching the supporting ligaments. For management, we're going to address all open wounds, assess CMS, correct any gross deformity by applying gentle traction to the heel if possible, and then before releasing that traction, go ahead and apply a splint. For foot injuries, this could be the result of a dislocation, a fracture of one or more of the tarsals, metatarsals, or phalanges. Toe fractures are especially common. Of the tarsal bones, the calcaneus or the heel bone is the most frequently fractured, and this often occurs when a patient falls or jumps from a height and lands directly on their heel, which is kind of what you're seeing here in the picture. And then that force can also be transmitted up the leg into the pelvis and the lower portion of the spine. So you end up often getting a fracture of the lumbar spine as well. If you suspect the foot is dislocated, make sure that you're assessing CMS. If they're present, immobilize using just a regular splint. If not, and you don't find any pulse there, go ahead and call medical control. Injuries of the foot are often associated with significant swelling, but there's rarely like a huge deformity that you're going to see. Vascular injuries are not very common. Lacerations around the ankle and foot can definitely damage important underlying nerves and tendons because there's a lot of connection points. You may have puncture wounds to the foot. They're common. They can cause serious infection, but oftentimes there's not a whole lot of what's going on there. To splint, apply a rigid air splint, pillow splint, etc. to the joint and the foot. Leave the toes exposed. And then if you can, elevate the foot approximately 6 inches to try and minimize some of that swelling. For strains and sprains, you want to treat every severe sprain as if it's a fracture. General treatment includes RICEs, so rest, ice, compression, elevation, and splinting. And that's mostly all it's going to take. But to rule out fracture, you do have to transport them, or at least have them seen by their primary care physician. For amputations, you want to control bleeding, treat for shock, and make sure that you take care of the amputated part because surgeons can occasionally reattach that. They're getting pretty good at that. With partial amputations, make sure you immobilize that part with a bulky compression dressing to try and prevent further injury. You may need to put a splint on as well. We're not going to sever any partial amputations. You want to control bleeding from the stump. And if the bleeding is extremely severe, go ahead and put a tourniquet on. With a complete amputation, wrap the part in a sterile dressing, place it in a plastic bag, and then your local protocols should be in place to preserve amputated parts. Place the bag in a cool container filled with ice. We want to cool the part without allowing it to freeze. So we're not going to put that part directly on ice. And you should never put it in water. Compartment syndrome, we've talked about before, often occurs with a fractured tibia or fractured forearms in kids. It's often overlooked, especially in patients with an altered level of consciousness. Compartment syndrome can develop within 6 to 12 hours after the injury, usually because of excessive bleeding, a severely crushed extremity, or rapid return of blood from to an ischemic limb. The syndrome is characterized by pain that is really out of proportion to the injury, pain on passive stretching of the muscles within the compartment, pallor or paleness, decreased sensation, and then decreased power. The muscle just doesn't work like it should. If you have a pediatric patient with a fracture below the elbow or knee, be on the lookout for additional. So extreme pain or decreased pain sensation, pain on stretching of the affected muscles, decreased power. They may not exhibit the pallor like the adults do, but all of those are indicated that the pressure within the fascial compartment is elevated. If you suspect the patient has compartment syndrome, splint the affected limb, keeping it at the level of the heart, and provide immediate transport. And make sure you continue to reassess CMS throughout your transport and let the hospital know what you have coming in and what you suspect. Remember, we don't diagnose, but what you suspect, because they're going to have a surgeon on standby to take care of that pressure. Other than that, this is it for chapter 31.